Welcome everybody to the second edition of the Meet webinar, dedicated indeed to meeting top colleagues from the Middle East region, but not only, of course, because there is a strong involvement of North Africa, Near East, and all the world. We deeply thank for following this educational adventure that is always starting from the Italian pavilion that you can see reported over here with the spectacular image of its roof made by 3 upside-down boats, a metaphor of the journey we are all having, particularly in this challenging post-pandemic, finally, time that taught us that indeed the difficulties are opportunities, in this case also indeed of meeting new expertises and new stellar groups like the ones involved in the Middle East and the vascular training indeed. I'd like to deeply thank all the societies involved, in particular in this project, particularly from the region, and also in particular the French Society of Phlebology for reaching out globally with the presence also of the French simultaneous translation. Indeed, we look forward for being all together in person in Dubai in few months, for the Universal Expo, connecting minds, creating the future as per the line of the Expo, but also connecting experts to properly inform patients as per the line of the V-Winter 2022 meeting in Dubai. In honor of the venue of the Expo, indeed you see over here 4 marvelous pavilions, the one of Saudi Arabia, the one of France, the one of Spain, and the one of UK. We will enjoy more than 190 countries over there with the spectacular pavilions. These 4 are in honor of the 4 languages we are providing simultaneous translation in today. So remember to choose the language you want in the interpretation button. Remember that you have a button also for making questions in whatever language, not in the chat, that is for like social communications more. If you want questions and answers, just choose the right button. If you want international CME credits, they will be provided together with the certificate, so refer to the organizing secretary for this. I'd like to deeply thank the colleagues and friends who joined from all around the world previous Saturday edition, and I'd like to deeply thank the ones we will introduce properly one by one today. We'd like to deeply thank also Alpha Sigma and Medi for having made possible this educational adventure in such an unbiased and productive way. As always, nothing would have been possible without the ones I consider family and perfect examples of professionals. So the mic now goes to Professor Bottini in Argentina. Oscar?
Once again, we are here sharing with you this proposal called Meet. It is a pleasure to attend.
Thank you so much for being as fast as Willy. Unfortunately, Willy sometimes misbehaves. He has a sudden commitment from which he cannot be with us today, but is leaving a message for all of us. And we thank deeply Professor Chi for always being present in all the designs of the activities we do. And I would say that difficulties are opportunities, because the difficulty of not having Willy with us is the perfect opportunity to properly thank Professor Matthew Josnin and also all the French Society of Phlebology for reaching out globally in this project that is also aimed to increase the presence of the French languages in the different initiatives. So now the mic goes to France for introduction from Professor Josnin. Matt?
Thank you, Sergio. Thank you for welcoming. Welcome, everybody. Very happy to see you again for this second session of the Middle East endovascular training. Thank to the organizers, Sergio, Oscar, and Willy, for their work and the invitation. And it's a very huge opportunity to have this translation. I think it's a very, very good idea. Very good session to all.
Thank you so much. And nothing would have been possible without the fundamental support of Professor Martin Marash from Bahrain, who started building the bridge with us toward the Middle East region. So Martin, a word from you.
Sergio, ciao. It's great to see you again. So it's a great pleasure of mine to welcome everyone all around the world on this Middle East endovascular training, which is educational activity of Vivian Foundation. And we have started with 3 webinars. The first was very successful, I can tell you. I have had a lot of positive feedbacks. So let's go ahead with the second one.
Thank you so much to you and to all the societies involved in this MIT project. Indeed, it's always a group effort in the vision of bwin. And I say that it is really spectacular what happened in reality in the preparation of these educational online activities, because of course we always touch also the public health awareness topic. And in the preparation of the activities in Dubai, we met a huge professional in the person of Nesreen Halima, who is actually from Egypt originally. Well, fate looks at our actions, I would say, because we found out that in another webinar we did, there was the mother of Nesreen involved spontaneously by our group from Egypt with Wasila Tah. So it was an incredible coincidence. And for this, we celebrate these excellent women. And we have a welcoming also from the public health awareness perspective from Nesreen.
Good morning, and thank you for the invitation to join this wonderful meeting of minds and change makers from around the world. It is a pleasure and an honor to introduce the Middle East to you, and I hope the beginning of many great things to come. As many of you know, our region is a predominantly young population, driven with energy for the many changes that are transforming our countries. This presents us with a responsibility and an opportunity to benefit from minds such as yours, and also to work together and collaborate to address the many health issues that are associated with our region, and importantly, the social issues and misconceptions that underpin them. Thank you again.
And with this, we deeply thank once again Nesreen, and we have a welcoming from the region in the person of Professor Iyad El-Fateh from the Saudi International Radiology Society.
Hello, my name is Iyad Fateh. I'm an interventional radiologist and an assistant professor of radiology and the head of department of radiology at the University of Jeddah in Saudi Arabia. I'd like to first thank the organizers for asking me to present this short word to welcome you all to the second installment of the Meet in the Middle East webinar series, which is going to be about non-tumescent and non-thermal techniques. I would like to welcome you all on behalf of the Saudi Interventional Radiology Society. It's an honor, it's a privilege, and a pleasure to welcome you all. And I hope to see you soon when you do visit Saudi Arabia. And we would like to hope that you enjoy and benefit, as I'm sure we all will, from the upcoming lecture series. Thank you very much, and good luck to all, and welcome.
With this, we deeply thank the Saudi Arabia group, and we also congratulate for the Ducati backdrop on Professor Haide on the Italian motorcycle brand. And then we have a final remark from Tunisia with Professor Tawfiq Bouhamed from the Tunisian Society of Vascular Medicine, and he is with us live. So if you want to say a word, Professor Tawfiq.
Oui, bien sûr. J'aimerais bien remercier les organisateurs de cette manifestation.
Yes, of course, I would like to thank the organizers of this meeting. It is a pleasure, and I speak on behalf of all Tunisian physicians specialized on this topic. It is a great opportunity to exchange know-how, experience, and updates. We use venous endovascular interventions for many years. We have quite a lot of experience and perspectives on the topic, but to exchange ideas with you and with my friend Sadie, updates and experience will be a great opportunity. Thank you very much.
Thank you again, everyone. And in this way, we also gave the time to the audience to join. I see we are already many, so we can get started with the scientific part that is dedicated indeed to technical notes and evidence-based data on endovenous superficial devices. We treated the thermal tumescent topic last week. Today we focus on non-thermal, non-tumescent, focusing not just on the occlusion rates, but on all the parameters we have to take into consideration in this analysis. I couldn't be happier and more honored in introducing a significant figure from the region, Professor Shagran bin Khamis, from Saudi Arabian representation of the Saudi Interventional Radiology Society, telling us about the technical notes we should have on non-thermal, non-tumescent. Now the mic is yours and you can share your screen. Perfect, we can see it perfectly. You just go full presentation.
Am I good to go?
Yes, ready to go.
Okay, perfect. Welcome everybody. Welcome to the second installment of the Middle East Endovascular Training online webinar sessions. First of all, of course, I'd like to thank the VUEN Foundation for our organization and for the invitation. I'd like to thank the rest of the organizers as well as the Saudi Interventional Radiology Society for allowing me and giving me the opportunity to talk today. So we're going to be talking today about non-thermal, non-tumescent techniques in terms of instructions for users. My name is Shagran bin Khamis. I'm an interventional radiologist from Riyadh, Saudi Arabia, and King Faisal Specialist Hospital and Research Center. These are my disclosures in relation to the talk. And this is the hospital I work in right now, which is the Tertiary Center for Oncology, Transplant, as well as Vascular Disease. And we'd love to meet you guys here soon and to share our experiences together. This is the outline of the talk. I know it's supposed to be, or the topic is step-by-step instructions, however, or instructions for use. However, I think part of the instructions is knowing the product, knowing at least some of the data, how to choose the patients, as well as how to take care of the patients after the procedure. So I'm going to be talking about the VenaSeal system, since it's the one we use mostly in our hospital and we have the most experience in. As most of you know, it's a cyanoacrylate-based adhesive, which is formed of a catheter, as you can see here in the picture on the top, and it's formed of a dispenser, which is like a trigger, like basically a gun. The glue itself is uses the technology of coaptation, which is basically getting things closer together, so getting the vein walls close together and stuck together. The main property of the glue is that it's soft and elastic, so it's ideal for dynamic parts of the body, and it's usually a good or a more common option or requirement or request from patients that are younger or athletes in our experience. And it's considered an implantable device and not a drug. It has some contraindications as well as some complications similar to other modalities of treatment of varicose veins. However, the main issue that we usually talk to the patients about is previous hypersensitivity or the more common chance of developing phlebitis post-procedure, and we talk to them about this. What are the main advantages of using non-tumescent, non-thermal, or VenaSeal in general? Number one is you don't have to use compression stockings, which patients love, especially in our region where it's very hot. There's less post-procedure bruising and pain because of the non-tumescent use. There's no risk of thermal injury and patients can go back to their usual activity very fast. And I think very important as well is there's no capital equipment, so you don't have to purchase a RF generator or a laser machine to use these cases. And it might be important depending on what kind of institution you're practicing in. In terms of clinical data, I'm not going to bore you with it a lot. We're just going to just show if it actually has reasonable data or not. So they started off with a feasibility study. Then after that, they did a safety and effectiveness study. After that, they compared the VenaSeal to their own RF machine. Then they did a post-market study. And then they did an extension for 5 years. So what did the 5 years data show? It showed an overall occlusion rate of approximately 95%, 94%, which is very similar or close to the very well studied and older devices in the market. How do we select our patients? Basically, we select them the same as we select other patients in terms of treating reflux in the great saphenous or short saphenous veins, but which patients might be more ideal for using non-tumescent, non-thermal. Number one, if you're going to be close to the saphenous vein or the saphenous nerve, or patients that will not tolerate compression stockings or have some phobia from needles, if they have a much more active lifestyle, such as an athlete, or some patients are requesting more innovative or newer technology or cutting edge technology, they might like this kind of techniques. So let's go to the beef of the presentation, which is the step-by-step instructions. So once you open the box, you're going to have all this equipment here on the top. We usually separate them into two parts: the wet part, which is the sheath, the blue one, and then it has the dilator in it and has a wire. And then you have the dry segment, which should not be wet or get mixed with anything because it has the glue, which is the dispenser, the needle, the glue, as well as the gun. You're going to first take the glue and you're going to start aspirating it slowly. It's key to aspirate it slowly, otherwise you're going to get large air bubbles, which might affect the quality of the glue. After that, if you have any larger air bubbles at the ends, you need to flip the needle and you need to get rid of the air bubbles, wipe it with a dry gauze so that you're ready. Then you're going to take the syringe that you took the glue out and you're going to connect it to the plastic or the transparent dispenser that I showed in the first picture, in the last slide. You're going to hold the gun and you're going to press on the button here on the top, which is basically the same button here on the top here, number 3. And then you're going to pull back on the part here on the back to give space for the needle or the syringe to get inserted, as in this picture right here. Once you insert it, you're going to twist it so it's locked in place. Then you're going to start pushing on the trigger so you can push the glue into the dispenser or into the catheter until it reaches to this laser marked marker, which is approximately 5 centimeters from the tip. Once it reaches there, you're going to stop pushing it. Then you're going to have the patient, of course, going to be ready and prepped. After you mapped everything together, you're going to access the saphenous vein as you would usually access, push the wire across the saphenofemoral junction, and then you're going to take the dilator and the wire out. You're going to flush the introducer and then keep the syringe. Usually we keep it on. After that, you're going to get your ultrasound machine. I'm going to show you a picture of what it looks like. You have to pull back the catheter or the sheath tip 5 centimeters from the saphenofemoral junction. Then you take the white plastic one, the transparent one that has the glue, and you're going to insert it as in this part in the corner of this picture. Once you reach, there's another laser marked here, which is 5 centimeters away. Once you reach there, you're going to pull back this sheath backwards into the other sheath. The other way is doing it is having it 10 centimeters away from the beginning, and then you're going to push it in all the way. Then it's going to come out somewhere here, and it's going to be 5 centimeters from the saphenofemoral junction. After you're there, you have to verify the tip with ultrasound. It's very easy to see on ultrasound if you have reasonable skills. We're going to see it here on the sagittal view. It's very clear to see. And on the axial view, it has the star appearance thanks to the openings here in the catheter that are filled with air. After that, you're going to get your ultrasound machine and you're going to compress the saphenofemoral junction in a transverse fashion. And then you're going to start dispensing the glue. The glue is dispensed in a way according to the IFU. At the top, you usually inject 1 drop. Then you pull back 1 centimeter, you inject another drop, you pull back 3 centimeters, and then you compress in that area for 3 minutes. It's very important that when you're dispensing the glue, like in this picture, is you have to hold the trigger for at least 3 seconds. If you hold less than that, you have less amount of glue and you're not going to have appropriate adhesive cooptation. After you finish the 3 minutes here, as in this picture, you're going to check your tip again on ultrasound, like on the picture on the left here. Then you're going to do another drop, pull back 3 cm, and then hold for 30 seconds. After that, you're going to repeat this until you reach the end of the vein. So 1 drop, 3 centimeter, 1 drop, 3 centimeter. Every time you hold for 30 seconds, it's usually fast from there. Another option, if you have more experience, is you can do double or triple injections. So you do, instead of 1 drop, then pull back, you do 1 drop, pull back, 1 drop, pull back, that's double. Or you do the same thing 3 times in a row and then you compress. But you have to make sure you're compressing the whole area. So it's going to be a larger surface area. If you don't compress the vein very well against the glue, you will not get adequate adhesion. After you finish the whole part, as you can see here, you reach the end of the catheter. So usually this part is the plastic part that was inside, or the transparent one. It will start showing at the edge of the skin here. Once you're there, you're usually done with your treatment. So if you want to follow the IFU, you're going to release the dispenser from the sheath, as in this picture, as it's here, and then you're going to pull it back into the sheath so it's completely out of the vein. Then you pull everything out together. With experience, what we do, once we reach this area, we just take everything out, making sure there's no remaining glue at the tip. This is the appearance of the glue at the end of the procedure, and it's usually very fast. It takes about 15 to 20 minutes if you're only doing 1 vein. If you're doing more than 1 vein, you can keep going as well. So that's basically the step-by-step. Post-procedure care is similar to all other procedures, except they don't wear stockings. And we always tell the patient that there's a risk of developing an allergic or sensitive hypersensitivity reaction. The way I explain to the patient is basically like you're having super glue on your finger. Sometimes it becomes a bit red. You'll have the same thing here. So some centers prescribe anticoagulation, which we don't do it routinely. We routinely prescribe ibuprofen for 7 to 10 days, and we ask the patients to take it no matter what, just to prevent this kind of hypersensitivity. And then no stockings, but however, some patients will benefit from stockings, but mostly not. And then we tell them that they can return to normal activity within a couple of days. So in conclusion, this is a simple technique to do it. There's no capital equipment. I think it's very good for hot countries like in the Middle East, and the patients have reasonable recovery and return to normal activity. Thank you very much for your time.
Thanks so much to you, dear Shagran. It has been an excellent presentation that is deserving indeed excellent experts involved in the water discussion. We start from Tunisia with Professor Naima Sairi from the Tunisia Society of Vascular Medicine. He's here with us, and I'd like to deeply thank once again the Society for taking active part in this project. Naim, the mic is yours.
Merci Sergio. Je vais parler en français. Donc, tout d'abord, je tiens à remercier les organisateurs pour leur invitation. Je félicite également.
Thank you. I will speak in French. I also thank Professor Shaikham for his excellent presentation. Now, with respect to the non-tumescent techniques, if these techniques prove efficacy, are proving efficacy, but are very costly as compared to other techniques. Also, for the time being, these techniques in North Africa are not available. And another comment has to do with the fact that when we use this glue in the venous system, it may turn and stay up to 3 weeks after the treatment. Many experts recommend anticoagulant treatment after using the glue. My question for Professor has to do with practical issues. Is there a limit of the diameter in the small or great saphenous vein and the junction? And if there is, first. And second, is that available for the large veins? Can we use more product, more compression time, and this can increase the risk of complications? That is the first question. The second, when we do perform the technique, is there a risk of obstruction with the catheter, with the glue? And in that case, how can we recover the catheter? Thank you.
Thank you so much. Shagran?
So I'll answer the second question first. So in terms of risk of obstruction of the catheter, I haven't seen any cases in our practice. I haven't heard it so far. The glue itself is not the same as other glue that's used in other embolizations, such as in the abdomen or in the brain. And it takes a long time to adhere. There's another type of glue from another company, which I forgot the name, which they recommend to do it faster because the glue might get stuck. So we haven't had so far that experience at all. In terms of equipment, in terms of money, yes, it is a little bit more expensive than the rest. However, we got reasonable deals with the companies, so it's almost the same price as doing laser or RF. It hasn't been a big difference in terms of budget-wise. In terms of the size of the vein, so they recommend the size not bigger than 1 centimeter, but with experience, you can go a little bit larger. So when there's an area that's a little bit larger, or there's a big tributary in that region, we would inject maybe an extra drop of glue or extra 2 drops of glue, a little bit separate from each other so that we can compress it very well. And it usually does very good. However, I wouldn't recommend that until you have a little bit more experience in doing these kinds of procedures.
Thank you so much, Shagran. We just finished this morning the first in-person meeting of our group in Italy, and we discussed about guidelines. And sometimes we get out from the guidelines, so we should have the guideline of moving to the next discussion. But since we have Nuttaut with us, who is a huge expert from Thailand, I would ask Nuttaut if you'd like to comment as well on this topic with your large experience. Nuttaut, can you hear me? Unmute yourself. Yes, I'm going out a little bit of the guidelines, as we sometimes do, asking your opinion about what has been shared, because you have a huge experience on this as well.
Yes. What is your question about?
So we are talking about caliber, size,
For the caliber, I also did not stick to the IFU. In some case, in the larger vein, we put more amount of the glue, same as Dr. Shagran said in his talk also.
Thank you so much. And I encourage everybody to PubMed Professor Nutthaut, because he's publishing very interesting papers on this topic. Now we move to a very important moment in which I have the honor of connecting the two presidents of the two meetings we lost a UIP General Council, Professor Bottini in Buenos Aires this September, and it will be introduced by Professor Bottini, the other president who will have the General Council at the board meeting of the UIP in Istanbul. Oscar?
Thank you, Sergio. Let me introduce Dr. Kursat Bozkurt, who is the president of the next UIP Congress in Istanbul and a good friend. Kursat.
Thanks a lot for the invitation for both of you. May I share my slides, if you
Please.
don't mind? Yeah, I have. Right. First of all, I'd like to thank for the presentation. It was really great. I have some short comments on different glues in that occasion. First of all, in the market, there are 3 glues available. We know all Venacil is the first one, but we have 2 more, Venabloc and Variclose. Both are in the European and world markets at the moment. There are some important differences between those. As my friend previously told, the polymerization time of Venacil is longer than the Turkish glues, which makes a big advantage for it. The action is slowest for Turkish glue. For the other ones, it's faster. For example, the polymerization time is only 5 seconds for Turkish glue. It's longer, definitely longer than the American glue. Viscosity is water-like for Turkish glues, which makes life slightly easier. And as you can see, the main disadvantage of Turkish glue is you cannot use for both legs because of the very quick polymerization time. For Venacil, you can use for both legs. Yes, there is one disadvantage. Another disadvantage, Turkish glue is a firm one. The American glue is more flexible. There are some important differences between those. But if we look at the scientific data, there are 3 important studies published so far in the world. Our study, Morrison study, and Errol study. In reality, 3 of them did show the same results, even for complication or the other points of view. For example, in all glues, there's a big difference at all from paresthesia rate, from pigmentation rate, from phlebitis rate. So that means 3 of them can be used alternatively in different occasions. In the recent European College of Phlebology guideline, which was published last year, we did suggest glue ablation for 2AA recommendation. You're gonna ask me why you didn't say 1A recommendation. There are some questions in my mind and in the world scientific people mind. First of all, there are some data regarding the allergic problems, which is a problem. And the second question is granuloma formation. There are some few cases granuloma formation with Venacil, 1 in 10,000 patients, but definitely they may have some disadvantages for the future use. So, but remember, every phlebologist, every radiologist or surgeon should have thermal and non-thermal techniques together. For example, this is one of the patients I did treat 10 years ago with radiofrequency ablation, just when a saphenous magnet stayed open with glue, without putting the patient again in a thermal procedure. You can just give a glue to the saphenofemoral junction, which I did here. Can you see the saphenofemoral junction is on the right hand is totally blocked. Then for the rest of the vein, you can do foam ablation. As I told you before, every surgeon should have 1 thermal and 1 non-thermal techniques together in and different patients. Again, I would like to invite to UIP World Congress in Istanbul. It's going to be next September. And again, finally, thanks Sergio and Oscar for this nice invitation.
Thanks so much to you, Kursat. Shagran, would you like to reply to this excellent comment? Shagran, I see you are there.
Yes, I'm here. So I don't
Yes.
really have any experience with the other types of glue, but we have thermal and we have non-thermal as well as foam ablation. And as I definitely agree, you have to have more than one modality, as well as the options of doing phlebectomy. We have a lot of very good cooperation with vascular surgery, and we do sometimes our own mini phlebectomies, very rarely. That's our practice.
Thank you so much, Shagran. And now we fly on the other side of the Atlantic with a huge person that will be introduced by the co-chair of this webinar. Well, thanks again, Matt. The mic is yours.
Now it's my pleasure to introduce Dr. Kathleen Gibson, who is president-elect of the American Vein and Lymphatic Society, and a huge expert in the field with lots of publication.
And here is her comment.
Hello, and thank you for inviting me to give commentary on this excellent talk by Dr. Bin Khamis. And again, I'm a big fan of using cyanoacrylate, and I really enjoyed this presentation. One thing that was noted was that this is good for young active people. And one thing that did surprise me when I started using cyanoacrylate a lot is how much I really think it benefits actually my elderly patients, in particular because these are patients that sometimes have limited mobility, and to require them to wear a stocking or a bandage can be a problem. Many of them are on anticoagulation, so they have increased bruising, and they don't tolerate things like tumescent anesthesia as well as a younger person. So kind of paradoxically, even though we think of this for young active people because they can get going working out and everything right away, I found it really does benefit my elderly patients as well. In fact, I think it's maybe even the best treatment for them. Another group is those that are obese. That is the group where we tend to see the most recanalization with superficial venous technologies using tumescent. And I think that's because it's difficult given that they have increased central venous pressure. And I think cyanoacrylate may be ideal for them. So this was more of a comment than a question, but I want to see whether the author, our presenter, is in agreement with that, and whether he treats very many elderly patients in his area. I liked his point that it's really difficult to wear stockings in a warm environment, but what he thinks about for kind of the more fragile populations with varicose veins and his opinion on that. So again, I thank you very much for letting me deliver this commentary, and I look forward to being able to attend meetings in person in the future. Thanks again.
And we thank Dr. Gibson, and we remind also that there will be the AVLS meeting in October that, of course, is of great importance. Shagran, would you like to comment with Kathy on this?
Yes, thank you, Dr. Gibson. I really enjoyed this comment. Actually, my go-to technology for treating all patients or most patients with varicose vein or insufficiency is actually venous seal, unless proven otherwise. So if I have a reason where I cannot use venous seal, then I won't. Mainly if patients have had previous experiences with hypersensitivity or anything like that, maybe. Otherwise, for more obese patients, for fragile elderly patients, they actually like it much more than wearing stockings. They hate wearing stockings, even for regular treatment. Just for preventative measures, they hate wearing it. So that's probably our go-to treatment right now for most patients. I haven't used the thermal anesthesia, thermal technology in a while now.
Perfect. Thank you so much, Shagran. We wait to interact with you during the discussion. Now I have the honor and pleasure of touching, I would say, literally a hot topic about non-thermal, non-tumescent, indeed, as per this webinar, wondering with these experts if it is time, let's say, to stop the fire or not. These are my conflicts of interest. Well, I would say that I'm extremely interested in this topic because it's the prosecution of the group effort we did with many colleagues who I like to deeply thank, and many are also present today, following the VWinter 2019 meeting in the beautiful Cortina on the Alps, where we looked at the stars, basically, because the guidelines indeed are like stars. We follow these stars, not knowing in reality if we are looking at a body that is still alive or actually died long ago. And we also look at the similarities and controversies in the different guidelines around the world. So I invite you to have a look at the document. It's a 60 pages document with different chapters, including also endovenous saphenous ablation. Now, if we agree globally that there is a strong recommendation in using a thermal tumescent for the great saphenous vein, it's pretty impressive to notice that indeed the line becomes quite bumpy when you focus on the small saphenous vein. So we should already start talking about this. And of course, the road becomes even bumpier if we look at the line of the different non-thermal, non-tumescent techniques. So why should we eventually think about not doing a thermal tumescent? Because on one side, we can say that thermal tumescence is recommended by the guidelines, it's minimally invasive and fast. At the same time, we could say that tumescence can bother some patients. In reality, if done properly, this is not my experience. Rare but possible thermal injury, I would say, again, extremely rare. Potentially more cost-effective and faster, we should really demonstrate this before claiming this. So let's have a look, I would say, at what we have in the literature, in particular regarding the outcome measures we want to look at. Because as I said at the beginning of the webinar, we usually focus on the occlusion rate. And there is this constant fight in saying my device is closing better than yours. But in reality, it's not just about that. It's about patients' reported outcome. It's about cost effectiveness. It's about the clinical success at the end. A wonderful work by Bradbury Group showed us that, for example, in terms of anatomical success, thermal tumescent is more performing the ultrasound-guided foam sclerotherapy, but not that much if you're talking about clinical success and patient-reported outcome. Same for morbidity and complication. And in reality, if you look at the cost effectiveness, we could open a debate about who is really more cost-effective. We know that foam sclerotherapy is not perfectly performing in terms of occlusion rate. So there has been an attempt to improve the performance of sclerotherapy, let's say so. And in honor of Italy, I would say that the thickness of pizza really matters, because when we are looking at these data, we never take into consideration the thickness of the wall of the vessels we are treating by sclerotherapy. And indeed, it has been demonstrated that using a device that can facilitate the penetration of the drug, but not always also having an increased synergistic effect in the vasospasm, could help with the results. You see, for example, data showing us with the MoCA compared to radiofrequency, how we can have similar clinical outcomes with better postoperative pain control, a faster improvement in venous clinical severity score, but at the same time, more hyperpigmentation and more anatomical failures. Same more or less if we are looking at the comparison between MoCA and endovenous laser ablation. Of course, the follow-up is always pretty short, so we should discuss with longer follow-up terms. Also, in terms of cost effectiveness, it is interesting to notice how this group in 2018 pointed out that the new techniques like MoCA could be competitive in terms of cost effectiveness, even if the same group this year reported other data showing once again thermal tumescent at the first two spots. We have data now at 5 years also showing the performance of MoCA, in this case specifically of this device. We should always be cautious in not making confusion between techniques, strategies, and different devices. These data are related to this device. There are like also other devices like this one that are scratching the endothelium. We have preliminary data. This has been in the market for quite a while. So we look forward for having more data to really comment on this. As I said before, we have different kind of glues available in the market. This is an interesting paper showing in a meta-analysis the performance of, in this case, Vena glue in terms of the different outcomes you see over here, with a very good positioning apart the VCSS and the Euroqual 5 scores. It was already mentioned that there's a paper during this webinar in which they looked recently in 2020 at the performance in terms of occlusion rate and also of quality of life. You see that it is totally competitive, the use of glue, also in terms of complications. But at the same time, I would say we should always remember to use it properly to have the proper performance, because it's not just about the occlusion rate. And for sure, it's not about the occlusion rate when we are talking about so short follow-ups. So you see, for example, in this case, 99.4% at 12 months is an interesting data, but it has to be evaluated in the general aspect also with all the other parameters I said before, even if we're talking about a little bit longer follow-ups at 24 months, because in reality, we have to be sure that we are not creating complications, that we can manage properly the device, because indeed complication like a granuloma or a new complication that has been recently reported by an authoritative group of Professor Davis is, for example, the one of extravasation at 9 months with a foreign body reaction. So we really have to be properly trained before using these devices. These are data also regarding other glues available in the market. Again, we are looking forward for longer follow-up, and also pointing out, for example, that with the same, you see, product, you have significant differences in terms of occlusion rate at 1 year follow-up reported in this study at 98.6. But if you look at this very interesting paper by a very good Italian group also, you see that you drop at 94%. So it really depends on how we are looking at these data. All these considerations can be found in the document I mentioned before from the winter 2019, that is looking at the guidelines also for the non-thermal, non-tumescent techniques. Now, for example, you see MoCA entered, also glue entered in the recommendation. At the same time, I would say it's interesting to see how these stars that we are following, for example, the guidelines metaphor I was using before, are aging quite fast. This is the 2020 document of the European College of Phlebology that is confirming the role of thermal tumescent, saying that there are no data at 5 years for MoCA and glue. You see that indeed now we have data in the same year coming out for MoCA at 5 years, and we also have the VCROSE trial showing Benacin versus radiofrequency being extremely competitive. So to answer to the initial question, is it time to stop the thermal treatment or not? I would say that, first of all, it is time to stop fake news and fake claiming. This is, as you know, the mission we have now with the WIN of following this paper that is reporting that 40% of medical websites are actually including potential fake news shared hundreds of thousands of times. So I would like to brainstorm with these stellar faculty of today about the claims that sometimes we see in the literature about the benefits of NTNT. Is it really true that it is more cost-effective, more clinical effective, faster, that there is lower pain, that it is more office space? And is it really true that we really don't need compression stockings considering they are like anti-inflammatory drugs? Well, let's debate about that, and let's make sure we have proper outcome measures to discuss about this. Also because a recent Cochrane is pointing out that indeed we need to move forward with the proper outcome measures. For this, I invite all of you to report eventually encountered fake news in the dedicated website in the WIN page. I deeply thank all the more than 70 scientific societies involved in the group effort that will lead us to the creation of a consensus document to be presented in Dubai. With this, I now hope that Dr. Moigel from Saudi Arabia joined us so that we can enjoy his question to me. Can is Dr. Moigel with us, or Shagran, do you have news from Dr. Here he is. Nice to meet you. You're on mute. You're on mute. Mohammed, you're on mute.
Yes.
Here you are. Nice to have you with us.
Hello for all the group, and I thanks the organizing for this webinar, for this kind of invitation.
Thank you. Do you have a question or comment on what I just said, or do you agree 100%? I'm happy if you agree 100%.
Well, you know, personally, I'm running a very busy clinic of varicose vein in Saudi. We, you know, still the thermal ablation is the attractive mode of treatment with us. It's the glue is available in the market. MoCA is much less. I don't know why MoCA is less, but we're doing plenty of ultrasound guided sclerotherapy, not MoCA. The glue is now in the market, but it's still is not that competing much with the thermal ablation, especially the laser. So I don't know what's the practice elsewhere in the among the group. Yeah.
And I think, Moigel, this is the most productive comment of the day, because it is pointing out how there are like very big expertise involved, for example, also in these webinars of ours. And it would be nice to have more exchange of expertise of this kind. For example, we've seen before with the beautiful talk of Shagran with Corset about the different expertise. The same thing happens in reality with venous active drugs. For example, in US and in UK, they don't have the availability of the drugs we have over here. So in a globalized world, I think it's very important to try to get together and move forward in an homogeneous and synergistic way. So thank you so much for giving the opportunity to point this out. And now we fly all the way to Peru, and then it will be Professor Bottini introducing the key opinion leader from the region.
Thank you. It is a pleasure to introduce you to the person whom I have seen grow up to be an excellent professional. Chunga.
Gracias, Professor. Thank you, Sergio, for the invitation to meet once again. As always, a presentation that motivates us to investigate more and to debate even more. I think that the first thing we must take into account for stopping the fire is that not all varicose veins of the lower limbs are dependent of the saphenous vein. Therefore, as phlebologists, this is not our main concern, and we must be more trained in techniques that can eliminate all kinds of varicose veins. On one occasion in my country, I went to a talk on phlebology for the general surgeon, because we don't have vascular surgeons in every hospital. And they mentioned that in many hospitals, as they did not have laser, the only thing they could offer to the patient was stripping. But most of the time, they only give medication and stockings. That is, they felt their hands were tied by these guidelines. But then these patients went to the phlebotomist office and we did solve their problems. And finally, I always have doubts when reading some of these studies because many of them in their conclusions said such a study on sclerotherapy was rejected because it is a non-standardized technique, which is, sclerotherapy is not standardized. But that is not why I am going to ignore the works of great Latin American masters with whom I have been able to share their experience. And I know that they have and will have great results when treating the incompetent saphenous veins. Thank you very much.
It's me, Juan, thanking you so much also because we are so close friends. I will allow myself to agree on disagreeing with you, meaning that foam is standardized. Of course, you have to perform it properly. Watkins published that we can standardize the technique and it is also reproducible. And this is a very good point that you are raising because in reality, it's about training and about education. So you are the master of sclerotherapy there in Latin America, particularly in Peru. So I really want to stress out that we have the opportunity of performing a proper foam when we are properly trained, using the proper syringes, the proper technique, following the proper training. And again, I have this ginormous question mark of where we are going with all these technological innovations if we don't start from the proper training, because down the road, in every office around the world I have visited, we do foam sclerotherapy. We might treat the saphenous trunk in one way or in another, but honestly, I think that the only thing that is in common all around the world at the end is sclerotherapy. Now, sclerotherapy is extremely performing, extremely safe, as long as you know how to manage it. So thank you so much for bringing this opportunity of a comment.
Sergio, I want to talk
you do.
One minute.
Yes. Yes. Let's agree and disagree. So really 1 minute. Okay. Yeah. So what?
Una cosa interesante que me parece.
It's something interesting that we discussed with SAT is the costs that in Latin America make it difficult to introduce these techniques. For this reason, it would be very good. And I think the main obstacle is to introduce these techniques, non-thermal, non-tumescent, with the possibility that everywhere can work in the same way with standardized protocols, as Dr. Chunga said, have better results. On the other hand, what is also important that is to know that in order to have fewer studies, we should dissociate saphenous treatment from the saphenous vein, from intrafacial veins or epiphacial veins or varices, epiphacial varices, because like many Latin America joint treatment, the results in adverse effects and complications is fluctuates, changes. This is a comment I want to make, and let us hope we can do it together.
Thank you so much, Oscar. And now I wish it was me introducing the next expert, because he's a dear friend, a go-to person for science. So I really encourage you once again to PubMed the person that will be introduced by another dear friend, that is Matt Josnan. So Matt, please take us to Asia.
Now it's my pleasure to introduce Professor Nutaut, who is a top expert and a leading figure from Majidul University in Bangkok.
Yeah, thank you, first of all, for inviting me to be here, and congratulations for your excellent talk. I have a question to compare between the many products among the market around the world, Vinasil, Vinabroc, and varicose. Which product is the best in the occlusion rate, and which product has the lowest complication, includes hypersensitivity reaction, granuloma, or Egypt, and what is the cause of the difference? Thank you very much.
I will be really fast saying I don't know, and I don't know how we can answer to that. Meaning that honestly, I tried, and Kursat maybe remembers this. We tried together to speak about this, because it to be our responsibility to have a head-to-head comparison. We did something similar when we tested a holmium laser in the past. So the model I would suggest is an ex vivo, and then you have a 3 centimeter treated with one and 3 centimeter in the same person with another one, because you are making, of course, a very intelligent question, because parameters that have to be taken into consideration, not to compare apples with oranges, are, for example, first of all, the hemodynamics. We published on Phlebology Journal some years ago that if you have an incompetence of the ilofemoral tract, the hypertension you develop at the terminal valve is leading to an odds ratio of 4.8. So it means you have 5 times more the risk of having a recurrence. So now if I have a population that is treated with Vinasil and another one with Venabloc, and I didn't report in the data collection that part, I'm already biased. If I'm comparing one group with a certain thickness of the wall compared with another, I'm going to have another bias. Another thing we are learning from these investigations talking about the inflammatory reaction is also the hypersensitivity. And you teach this to us, Nutaut, with all your experience. So this is a call to the companies. I think it would be a common interest for everybody to understand more and have a head-to-head comparison, so that we can stop having personal feelings, because, you know, the hands of Professor Kursat with that kind of product is surely not my hand, and Kathy Gibson hands is not the end of another one. So it would be very interesting to have an answer to your question that up to now, up to my knowledge, has no answer. So I failed you. Okay. Thank you so much, Nutaut. And then we fly virtually to North Africa and Near East. I don't know, Khaled, if we have Professor Ayman connected with us. Please give me a feedback about that, because indeed we are looking forward for co-working more and more with all the region, not only of the Middle East, but North Africa and Near East. And indeed, we have a representation from Egypt and one from Georgia. So Khaled, can you tell me if we have Ayman with us? If not, we have the recorded video with us already. Connection issues is maybe, so we go forward with the video.
Good afternoon. Thank you, Sergio, for the great invitation to be today with you. And I enjoyed your presentation. It was very good as usual. I agree with you that the non-thermal, non-tumescent technique for ablating varicosity is a very good and cost-effective method. Although I have 2 questions for you. Using the mechanochemical technique with the sclerosing material, do you think this, that they call MOCA, do you think this will increase the durability of the sclerosing and maintaining long time for the vein closure, or it may induce superficial thrombophlebitis with the chance for recanalization and recurrence of varicosity? This is my first question. My second question regarding the glue. Using the glue is also a good technique, but as you said, we have to leave a long stump about 5 centimeters from the saphenophyllary junction. What do you think this big stump may increase their ability and inducing the chance for recurrence for the varicosity. Thank you again, and enjoyed your talk, and waiting for your comment. Thank you.
And I deeply thank Ayman for this question. Please let me know, Khaled, if he's able to fix the connection issues as I know he's having. So my comment to this is that, again, it's the opportunity to brainstorm on the technique of a MoCA, because in reality, when you're injecting a sclerosant, at the same time, we go through the tributaries as well as through the perforating veins. Of course, in this case, we are talking about a liquid sclerosant. The thing that we could look at is the kind of inflammation it gives to these vessels, because the concentration is, of course, really low. We have experiences with the SFALT technique in which we use laser or radiofrequency to create a cork, and then we inject sclerosants. So on one side, you could have actually the benefit of treating already in a single stage also the tributaries. On the other side, you might have the issue of creating an inflammation that is not the sclerosing process. The problem sometimes is that there is a too mild sclerotherapy that is leading not to a sclerosing process, but rather to a thrombotic process. So if we look at the data that we have with 5 years of observations on MoCA, we have seen with the data presented before that in reality it is competitive compared to traditional sclerotherapy in terms of occlusion rate. Is not that much competitive as for radiofrequency and laser ablation, but as we said, it's not just about occlusion rate. So I think there is a huge potential in a MoCA approach. It would be interesting to study more the effect of the sclerosants on the tributaries, yes, but clinically speaking, they have demonstrated with a very good follow-up that there is no increased risk of thrombosis in this aspect. On the other side, we could debate on how this thrombotic presence has been assessed or not, because we know also from an editorial of Yamaki that we don't have real data for talking about periprocedural management in terms of, for example, thromboprophylaxis and occlusion rate. The other question regarding the stump, I would reply again with the VICLOS trial. Looking at the stump of a radiofrequency ablation, then it will be more or less 1 or 2 centimeters versus the 5 centimeters of the venous, and they reported no significant differences. Up to my knowledge, there was no specification, though, about the hemodynamics, for example, of the iliofemoral tract that could have hindered the homogeneity of the two groups, but this is, let's say, high hemodynamic speculation. So up to now, it seems from the clinical data that is not making a significant difference in this aspect. With this, we move forward to Georgia, so with the other contribution from the region with a perspective indeed from the Georgian Association of Vascular Surgery.
Dear Sergio, dear colleague, thank you very much for your invitations to give me opportunity to take part as an expert of this very interesting meeting for endovenous procedures. Thank you speakers for their very interesting presentation. As you know, the number of the patients with chronic venous disease increased in the world, and before COVID-19 pandemic, a number of surgical procedures accordingly increased for more than 60%. That's why very important for the vascular specialist to decide what method of vascular procedure choose for each patient, which will be more effectively, cost effectively, and less traumatically for the patient. In the first presentation, Dr. Shagran Bikamis discussed about VenaSeal method, glue catheter-directed occlusive system. Advantages of this procedure are several, but I think prior are that this procedure does not need anesthesia at all, does not need compression stocking after that. You know that many patients are not tolerant to elastic stocking and they have some discomfort. The treatment effect of this method is very high, close rate. Dear Sergio has very interesting discussion. It was comparative characteristic of the statistical dates for many trials. He gave us information about the newest method for the glue occlusion system. It was the newest method is VenaBlock and VariClose. And interesting was the discussion about the new recommendation for the European College of Phlebology for truncal ablation, 5-year occlusion rate of mini-invasive procedures are high, 94 for radiofrequency ablation, 95 for endovascular ablation, endovascular laser ablation, and 94 for cyanoacrylate glue. All mini-invasive methods has a highest level of recommendation and class. Thank you very much to the organizing committee to organize today's meeting, and I hope the new organized international organization NENA will help our regional vascular specialists to treat their patients more effectively. Thank you so much. See you later.
And with this, we thank all the Georgian friends, and we move forward now with the audience discussion. So I ask Shagran to get ready because we are going to have some questions from the audience. We have 5 minutes dedicated to this. So let me see what we can have of interest here. So Shagran, I would pick up the question of Arnaldo Javier Estigarribia Bernal. It's in Spanish, so I will translate it for you. When we treat by Venacell, what should we do about the tributaries? I think this is interesting because it talks about stage or not stage treatment. So what is your approach in Saudi if you have a specific guideline, or how do you personally usually approach this? You prefer stage, not stage? We know that from the guidelines, they're now suggesting not to stage. And that, but we know also that there is a nice 2020 paper showing that there are some bias about this choice.
So a lot of it will depend on two factors. One, the size of the tributary. If the tributary is very large, first of all, I would add a little bit of glue near that section. And then if on the ultrasound it decompresses significantly post procedure, I ask the patient to stand up and I see, then maybe I will stage it. If it's very large and doesn't really change, or sometimes at the beginning we just treat it right away. The second part is in terms of the patient themselves. Some of them actually do not want to do everything at once. They would like to do one and then wait a few months. And then when they come back, whatever's left, we would either do some sclerotherapy or we'd do some phlebectomies. So it really depends on the patient as well as the tributaries also responds to just the closure of the saphenous vein.
Thank you, Shagran. And now we will take another question from Noah Attia, who is asking, what is the minimum caliber of the vein to use glue? Can it be used in the accessory saphenous vein? Well, yeah, it can be used, of course, in the accessory saphenous vein as long as you stay, of course, in sufficient depth, not to be too close to the surface. Always remember the potential inflammatory reaction. Regarding the minimum caliber, I think it is very interesting because it was recently published by Cho in 2020 that in reality, the smaller the caliber, the higher the risk of having an EGIT, so an endovenous glue induced thrombosis. That could be interpreted, I would say, because of the smaller caliber, so of course the facility of the glue to progress. I would like also to have a comment on this from Nuttaut and Kursat because they are huge experts in the field. So I would say that, of course, when you go below 5 millimeters, I have a question mark that is pretty big on why you are treating that saphenous vein, because very probably you could treat just the tributaries and fix the issue, first of all. So I wouldn't go like so low caliber. But also, I would like to point out that lower caliber might be an issue for EGIT, according to the recent publication, and also advanced stage for some reason. So I would like to take these last 3 minutes of discussion with Kursat and Nuttaut to discuss on these topics, if you like.
Yes, yeah.
Let's start with Nuttaut. Yeah, well, Kursat,
okay,
you go.
Okay.
First of all, in our country, we have some limitations for using glue. If the size of the vein is below 5.5 millimeters, the government is not reimbursement. So practically speaking, if the size of the vein is below 5.5, you can't get any money back. So I personally don't do anything below 5 millimeters. So it's my rule. Usually this kind of saphenous veins do better after miniphlebectomy. So I have no experience yet, but practically speaking, if you want to do, yes, you can do. Yes, you can do. I don't think, Sergio, there is a big issue for thrombosis, propagation of the fetus, of the thrombus like that in that occasion.
Nuttaut?
Yes, for my practice, for the vein, saphenous vein refracted, I usually treat with venous abrasion like the venous seal, the vein size is usually larger than 6 millimeter. And I have an experience in our recent publication in Journal of Vascular Surgery that if the vein size is larger than 8 millimeter, it is a higher risk of the hypersensitivity reaction. And also if the vein is very close to the skin, there is also the risk of the hypersensitivity reaction. So in this part of the vein, if the vein is close to the skin, I usually perform the phlebectomy, but I did not choose the venous seal as the first choice when the patient who would like to perform the phlebectomy. I usually perform the RFA or thermal ablation with the phlebectomy, because if we choose the venous seal, that the cost is double for the RFA, and this is the non-invasive, but plus with the phlebectomy, this is invasive. So the total is the invasive, and it's the higher cost. And I think it's not necessary for me. Thank you.
Thank you so much. Just a short question to Matt, and I would like to ask also Mohammed Anwaijel, if he's listening to us, about to anticoagulate or not to anticoagulate in venous seal, and if giving anticoagulants in case of EGIT or not, because there are contradicting papers on this. So do you put thromboprophylaxis after venous seal to everyone or just in specific cases? And in case you have a propagation, would you put would you put anticoagulants or not?
Routinely, I don't anticoagulate the patient unless the patient is either obese or a lengthy procedure. So I give subcutaneous Clexane, just single dose. This is in case of if there is any issue of during the procedure, but routinely I don't anticoagulate. Now, if there is any propagation of the thrombus or the glue, yeah, I anticoagulate. I start anticoagulating, and I follow up the patient. Though it's very rare, it happened to me just once. So I anticoagulate and short follow-up. I think more important, and warning the patient if the patient having any signs or symptoms of shortness of breath or signs of PE. Yeah.
What is short for you, Mohammed? What do you mean by short? What is a short follow-up for you? Because for somebody short is 48 hours, 1 week. What is a short follow-up for you?
I see the patient the following day, because luckily the patient is not wearing any compression stocking, so it's very easy to do ultrasound. And then 3 days, 4 days, and then week, and then 2 weeks, and then 2 weeks is very important, and then 4 weeks. Yeah.
Thank you so much, Matt. A friend's perspective on this, Matthew?
Yes, exactly the same in France. There is no indication of anticoagulation without patient with risk of thromboembolism risk, and if there is migration, yes, we anticoagulation with a follow-up for 3 or 4 days after. Yes, the same.
That is interesting, because I was reading contradicting papers on this with somebody doing that or somebody else doing so. Maybe a meta needs to cover together. So thank you so much to all the ones involved in the discussion. We move forward with a selected comment. The other time was from the region. This time is from another region that is indeed Brazil. And it is my huge honor and pleasure to introduce a huge expert in the field, Eduardo D'Amata from the ICC Brazil. Eduardo, would you like to share your screen?
Thank you, Sergio, for the invitation. And I'm going to talk about peri-procedure compression therapy. There is no conflict of interest for this presentation. And the aim of this presentation is to talk about compression therapy before and after procedures, lymphedema, in lipedema, venous ulcers, and post-procedures involved in the treatment of venous disease. According to guidelines and consensus around the world to the treatment of lymphedema, all interventions for chronic lymphedema should be preceded by at least 6 months of non-operative compression treatment. Non-operative compression treatment means, among others kinds of therapy, compression therapy, of course. And at the same to the treatment of lipedema, non-surgical treatments before at least 6 to 12 months, some invasive procedures. Here we can see that a specialized center can avoid invasive procedures, good results with only conservative treatments in lymphedema here and lipedema here. The congestive treatment, of course, for both of these kinds of treatments, and compression therapy of the main treatment. But when we have a surgical procedure, the maintenance phase with a proper compression therapy is necessary. This, we have a patient that was submitted of surgical resection. We can hear the scare, we can see the scare here, and in the past, of course, and she didn't keep performing good cares after the procedure with compression therapy, and evolved to this degree of lymphedema. And we treated these patients, of course, only with non-invasive procedures, and we have a very, very good results. And we have now the patients maintaining the treatment with compression therapy. Talking about venous ulcers, there is no doubt about there. Compression therapy is the first option with high levels of interface pressure. And the best way to get this strong pressure is an inelastic system. Invasive procedures in venous ulcers is recommended to prevent the recurrence, and the same about compression therapy after healing the ulcers to prevent recurrence. Concerning to compression therapy post-procedures, the level of evidence is low to see in the when we indicate after thermal ablation and surgery, and to improve the results. Concerning to symptoms, the level is a little bit better. And the reason for this is the pressure that is applied in the trials that we have seen in the past. The pressure has not been applied according to the venous hemodynamic. We can see here we need 90 millimeters of mercury in the lower leg, here 70 here, 40 here, and the stockings didn't get this higher pressure when we applied that. So as a conclusion, compression therapy before and after procedures in lymphedema, and venous ulcers, compression before and after procedure here. And post-procedure, we need more studies with proper pressure of compression when we need to diminish the lumen of the vein. Thank you very much.
Thank you so much, Eduardo. And now we fly back on the other side of the Atlantic all the way to Georgia to introduce another huge figure, president of the Georgian Association of Vascular Surgeon and Angiologist, also of Georgia, Tamara Abziendidze, a dear friend for translation properties, because we are, of course, really close to Professor Zaza Salvatore Lazarashvili group. Tamara, the mic is yours.
Dear Sergio, dear colleagues, thank you so much for the invitation. It is a great honor for me to participate in this webinar and take the first step towards membership in this great family. Many thanks to Professor Mata for this brilliant presentation. Professor Mata, you have shown cases of lymphedema and lipedema that have been treated conservatively without any intervention. Were the treatments complex or included only compression therapy? Did you also use some medications? Thank you very much.
Thank you very much, Tamara, for this question. No, I didn't use any medications, only at the congestive lymphatic decongestive treatment. And the mainly tool that we use here in our center is compression therapy, of course. Oh, but no medicaments. Okay.
This is a brilliant question because, Tamara, this is taking us back to the document of Cortina where we were showing a paper of BMJ 2018 showing that if we don't put homogeneity in the data collection, including exactly what you ask, we get the risk of putting together apples and oranges. The same for the CDP. If we don't standardize the CDP, we get the risk of not being able to demonstrate its benefits. So the importance of evidence-based data. Thank you so much, Tamara. Thank you so much, Eduardo. We look forward for being together in Brazil and in Georgia, and we look forward to keep on having evidence-based data. And for this reason, we have indeed, as an honorary member of the faculty today for the honorary final lecture, somebody that is representing evidence-based data, Professor Armando Mansilla, and it's an introduction from Porto University. And talking about evidence-based data, I'd like to congratulate Armando because International Angiology now has what impact factor? 2.8. So we are getting really close to 3. So congratulations for that. So if you want to share your screen and tell us what we should do next for improving thermal tumescent, since we have been speaking about non-thermal, non-tumescent so far, if we have to improve something. Can you share your screen, Armando?
Yes, of course. Good afternoon. Thank you, Sergio, for this kind of invitation. It is always my pleasure to join these initiatives. And I was asked to discuss what we need next in thermal tumescent techniques. We all know that these different techniques that are using tumescent anesthesia provokes an endothermal damage delivered through a percutaneously inserted device. And the most well-known and used endothermal treatment modalities are the laser, the radiofrequency, and the steam. What do we know about each other? Concerning the endovenous laser ablation, it uses electromagnetic radiation. The laser energy, it is absorbed by blood and converting heat. Steam bubbles are produced at the tip, and there is an homogeneous thermal injury to the endothelium. It is, I would say, and according to the literature, ideal for linear great saphenous veins with more than 5 minutes of diameter. But several procedural steps are involved, including that requires a continuous pullback of the fiber at a steady, continuous pace. So I would say that concerning laser, the limitations are that requires a significant operator skills. Several procedural steps are needed. This is an unstandardized treatment because different energy levels can be used, and it is needed a continuous pullback. Sometimes it's difficult navigation or even impossible to use in tortuous veins, and not recommendable on suprafacial great saphenous veins because of the higher risk of skin burns and pigmentation. Concerning radiofrequency, the thermal energy is delivered from a bipolar catheter directly to the venous hole, and this is more standardized as procedure and less operator dependent, so with less room for errors. I would say that the limitations are still a difficult navigation sometimes, and even impossible to use in tortuous veins, and the same not recommended on suprafacial varicose veins because of the same risk, or the same higher risk of skin burns and pigmentation. Concerning steam, the steam is delivered endovenously at 120 degrees and condensates into water and produces thermal injury. It is, at least in theory, a simple procedural approach, no need for guide wire or sheet, and the catheter is more small and flexible, usable even tortuous veins. But the main limitation it is we have still a lack of robust evidence. And what about the evidence and the literature? We can find many trials systematic reviews and meta-analysis in the literature, like, for example, this one published at the European Journal of Vascular and Endovascular Surgery, comparing laser radiofrequency and open surgery, and at this time without any significant difference. The same with this remarkable trial produced by Rasmussen with a follow-up of 5 years and primary outcomes, technical efficacy, clinical recurrence, and rate of reintervention. And again, without any important difference regarding laser radiofrequency and open surgery. And also this one published at British Journal of Surgery, trying to compare laser with STEAM with a follow-up of 12 months, not 5 years. And again, no difference regarding laser and STEAM, perhaps a less post-procedural pain and higher patient satisfaction, but with only 1 year of follow-up. So you can find wherever you want in the literature concerning the evidence and trials. And at the end, you cannot find important statistical differences between these different techniques. And the same for the international guidelines. If you go to read what was published by the European Society for Vascular Surgery or from Latin American Venous Forum, or more recently from the European Venous Forum, even in the recommendations and guidelines produced from these international societies are different from one from another, what is quite surprising and difficult to understand. And as I said, the latest one published at the International Angiology Journal in 2020 by the European Venous Forum, you can find a grade 1A for radiofrequency and laser, the same for open mother surgery, and just 1B for STEAM, as I heard in the previous discussion, and the same for the Venezio. What are the main limitations or complications of these thermal-tumescent techniques? I would summarize in 4 points that all procedures require this tumescent anesthesia, and sometimes it's cumbersome and painful. There are risks of skin burns and pigmentation. The endothermal heat-induced thrombosis with four categories that it is well known and published in the literature, and the recurrence from the saphenous strength stamps. So what we need next, and that was the question that Sergio asked me to try to answer. And this is difficult, Sergio, so I will not say if I want to say thank you to you or not because of this, but Mathieu will have the opportunity to share this discussion with me in the next period of discussion. What I would say that we need optimization of the heat transfer mechanisms, less risk of surrounding tissue damage, less need for tumescent anesthesia using these thermal techniques, and being more usable in patients with superficial epiphyseal saphenous strengths. The radial emitting proximal tips should have less risk of heat and also diminishing of the length of saphenous stamps. It would be important to improve the catheter flexibility, and so we can increase the treatment indications in tortuous anatomies and less risk of catheter fracture. And special for lasers to standardize these modalities, being less operator dependent, with a less learning curve and less risk of iatrogenic complications. I don't know if this will be or not the solution, and I'm not sure if this will be an advance, but just to share when other option already discussed, the echo therapy that uses high intensity ultrasound to cause thermal damage to the target vein, does not require this tumescent anesthesia, and does not cause skin burns or pigmentation. But of course, we have a complete lack of evidence of using this technique, and especially comparing with the other already proven techniques concerning the efficacy and results. So I would say in conclusion that the tumescent thermal techniques are established treatment option for varicose vein treatments. They are strongly recommended into different international guidelines, even if the grade of recommendation level of evidence is not the same for all of them, but it is strongly recommended with favorable profiles of safety and efficacy. Nonetheless, the current heat transfer mechanisms are associated with an increased risk of pigmentation and skin burns. There is still restriction to certain anatomies, the more tortuous varicose veins, and also related with the costs. This is my last slide, saying that the development of more flexible catheters with proximal radial emitting mechanisms around tissue-specific heat transfer delivery under intuitive and standardized protocols could significantly improve the current thermal technique outcomes, even without the tumescent anesthesia, if we can improve these techniques in this direction. Thank you for your attention.
It's us deeply thanking you, Armando, and congratulating you. So please stop sharing so I can proceed. And I'm sorry for you, but if you keep on giving such amazing lectures, you will be still invited on weekends, being busy than working rather than enjoying your weekend. And indeed, the honor goes with the honor of having another huge figure, that is indeed Professor Mathieu Josnen, President of the French Society of Phlebology, interacting with you. Matt, your perspective.
Dear Armando, thank you very much for this very high quality presentation, which allows us to position the techniques of endovenous thermal treatments very well. Their emergence and their use in current practice have allowed a clear evolution in the management of varicose vein and to relegate conventional surgery to a secondary level. They also make it possible to treat fragile patients, even those on anticoagulation therapy. Sedation remains very rare with this technique and is reserved for certain special cases, since all of this procedure, as you said, are performed under tumescent anesthesia. The use of radial and double ring laser fibers have allowed a clear reduction of certain side effects. The devices must indeed allow better distributions of the caloric energy to the tissue, as you said, in order to more specific and thus reduce the effect which should or not be expected. In all cases, these techniques have led to an improvement in pair and a clear reduction in work stoppage. I would like to ask you two questions. Do you think that we can expect in the near future a significant evolution of laser and radiofrequency devices that would allow us to improve the safety and prevent the side effects discussed here? And my second question concerns non-thermal and non-tumescent techniques. These techniques are in full emergence and allow us free from ourselves from a step that is often felt as unpleasant by the patient and often takes time, the tumescent anesthesia. These non-thermal, non-tumescent techniques are often performed in a simple consultation room and no longer require an operating room. Do you considering that considering the remarkable efficiency of some of them, such as glue, and the safety of use that goes with them, justifies the totally replacement of a laser and radiofrequency technique in the future? Thank you.
Thank you, Mathieu, for your kind questions. If I can, I'd make a few comments. First is all these techniques, laser and radiofrequency, I cannot put the steam on the same level, but for laser and for radiofrequency, they were that's for sure a great step in the treatment of varicose veins. Not only because they allow these procedures, as you just mentioned, being all of them on ambulatory basis and a local anesthesia, the majority of them sometimes with sedation, but but not only for this, Mathieu, also because of these different minimally invasive techniques, even the open surgery today is not that it was in the past, and for this reason, we have the modern open surgery based on phlebectomies that has the same level of evidence, and this evolution was, that's for sure, also associated with laser and radio frequencies and the developments of the laser and radio frequency. And concerning the future, I don't have any information concerning if we expect or not any kind of evolution on the radio frequency mechanisms. I don't have any information, inside information on that. I don't have at all. Concerning laser, yes, we know that there are always different laser tips and evolutions, and because of this, the laser today is not the same as it was 10 years ago, and the trials that were done in 2012, as I just showed, they are obsolete now. We cannot anymore base our conclusions on these results, because the bear types had a great evolution. And I would say that in my view, what would be a great evolution, it would have these thermal techniques without tumescent anesthesia. That would be a great evolution. But I don't have any information that I can answer to you that I expect that in the near future. I don't have that at all. And concerning the non-thermal, non-tumescent techniques like glue, the evidence is not so robust for now. In the latest guidelines, it is 1B. Of course, it has this enormous advantage of not being necessary, the tumescent anesthesia, but at least in my countries and in other countries, the costs are still too high to be supported by the health national system, and this is an important limitation for the current daily practice in our public systems. And another point that is not under discussion today, Sergio, but just to finish, is again, the majority of these trials are comparing the results on saphenous strengths. And we should have trials to compare the treatment of varicose veins, because varicose veins are not always and only related with saphenous strengths. And this is the point. So we cannot have all our mind always talking about saphenous strengths when you have the majority of varicose veins do not depend on this saphenous strengths, and in not all of them the distance and the length and anatomy of saphenous strength is the same for different varicose veins. I'm not sure if I answered to your questions, Mathieu.
It's very good. I understand. Very, very complete answer. Thank you, Armando.
Thank you. My pleasure. Thank you.
Thank you. Thank you so much to both of you. And there is no rush because it's perfectly the end of the webinar, but not the end in reality, because in Italy, we are used to have 15 minutes of academic delay, as we were saying the other time. I don't know if it is the same in France or in Portugal, but considering the stellar faculty, considering that today in Italy, we celebrated one of the first in-person meetings talking indeed about guidelines. And we said that sometimes we might have to get out from the guidelines. I would welcome other 10 minutes of discussion. So whoever wants to go, we finished the program. But whoever wants to stay, we go on debating with the stellar faculty we have over here, because we touch some very important points. I would start, Armando, discussing for a second on what you mentioned on HIFU, because of course, as you know, one of our main goals in the winning these days is focusing on evidence-based fact, no fake news, certification of the products, and so on. Unfortunately, we are in the paradox, up to my knowledge, for which validating a product means having a CE mark, for example, in Europe, and then you put it out in the market with eventual questionable literature behind. So when we are talking about these new technologies, in your opinion, before really advocating for their use, Should we have at least a strong prospective study? Because if not, also, for example, you said it is not too messy, but in reality, we know that you need some local anesthesia in an IFU procedure to perform it. In terms of costs, we know that we need thousands of euros to perform that. And we know at the same time that there was a 60% increase of the venous procedures from 2013 to 2021 because our population is aging and we are becoming fatter. And so the chronic venous disease, of course, is going on. So as huge experts, I ask on the panel, how would you feel comfortable like with no basically data there and all these products coming to the market? Should we as societies request at least a strong prospective study before claiming something? Should we label this? Because if not, you are exposed to commercials that can trick the patients. Same as for the standardization of the foam. We discussed this with Juan Chunga before. Armando, I don't know if you were already with us, but proper foam production is standardized or reproducible. So what is your vision in this? I asked this from Middle East to Latin America.
Well,
I don't know who wants to take this.
If I can start,
Please.
of course, I completely agree with your point. Not only for this, but for everything related with science and with medicine, we need evidence and we need regulatory committees. Otherwise, we are talking about marketing and fake news and other things that at the end, the population is not prepared to distinguish. And some of these treatments are in the level of over-treatment. And this is an important point for today, because sometimes we discuss and at our national systems, if we are treating or not all our patients, if we have waiting lists, what is true, and we have to solve that. But it is also true that especially in systems where the payment is completely related with the procedures, we have important over-treatment, and this is also true for varicose veins. And if you try, and this is, I can imagine that this is same around the world. If you want to say to the patients, please come to my office, to my hospital, to my OR, wherever, it doesn't matter. And we will treat your varicose veins, and this is non-invasive, you don't have to do anything, this is office-based, and 100% completely free of complications. You are not talking about science and medicine, and for this we did national societies, we need the regulatory committees, and we cannot forget in this equation, Sergio, that as we just discussed with Matthew, that we have several important treatments already proved in literature for varicose veins. And we cannot say that one is the only available treatment for all varicose veins. This is not true for no one, and this is not true around the world. Because we have different varicose veins, we have different patients, we have different reimbursement policies, and some of them do not allow us to have increased costs. And we should not forget that in this equation of trying to choose the best intervention technique for a different and an individual anatomical and hemodynamic pattern of varicose veins in one individual patient that sometimes is fragile, as you just mentioned.
Yeah, and I will just conclude saying that rather than having somebody claiming I'm the first at doing something in my country, that is a market, I would like somebody to say, I'm the first one publishing a prospective solid paper about this in my country. That would be a significant message, I think, for also the audience, because everybody can be the first doing something, but it's important it is a meaningful something. I see two raised hands, and Khaled, I see that we have Carlos Bonet among the audience. He's a huge expert and dear friend. If you can upgrade him to the faculty so he can join us for a second. Oscar, I see your raised hand, and then we have Martin.
Sí, me voy a expresar en español.
I will speak in Spanish.
En primer lugar,
First of all, to say the guidelines and recommendations, as Armando stated, in fact, have been elaborated to defend, as a defense against insurance and set conditions to be accepted, because there is always resistance, economic resistance from government and institutions to accept some treatments for cost reasons. In Latin America, this does not exist as such, because we do not have a strong impact on the governmental structure, let alone in our specialties. So even if it does not seem true in countries like Argentina or Brazil, what has been accepted by regulations is to do conventional saphenectomy, as we have known since the beginning, early last century. So there is no coverage for any other procedures, even the most economical ones. If we do them in the office, they are not accepted as such, for which reason all patients go to the operating room. And all patients have an anesthesiologist, which increases the cost enormously. The costs, because if also we have to apply techniques that are paid in dollars and for us are much more costly, this complicates care. I participated of the guidelines that Armando mentioned, and the major problem of guidelines is that they were based on papers, on works done outside Latin America, because usually there is no high scientific evidence of studies conducted in our continent until the guidelines were elaborated. So we extrapolated the treatments we do to results from other centers, or other countries. This is also a complexity, and tumescent techniques have had a strong impact, and a large number have been done from the beginning of the century for the possibility of increasing the levels of benefit for professionals in terms of treatment. The costs, generally speaking, are and have been higher. And so, in order not to take any more time, the comment is that we must try and see how we can reach those places, and these meetings are the right venue to do it, in order to get our institutions in Latin America to promote changes of behavior in the treatments we want to conduct. Without any further, I want to thank you and greetings to everyone.
Martin, a perspective from Middle East?
Sergio, it's just, I want to add, because
there are two devices open for you, Martin. You have to switch off one of the two.
Now, can you hear?
Yes. Good.
As Armando already highlighted, there will be always problem with the varicose veins treatment and chronic venous insufficiency, since there is so many treatment options and each patient is different, and also the circumstances are always different. So there is a different treatment in a private practice, there is different treatment in governmental hospitals. There are different circumstances because each physician is familiar with different treatment or techniques. And I just want to mention the insurance policies as well. And the insurance, unfortunately, they influence the treatment as well, because here in the region, as a great example is non-thermal ablation techniques are like twice or 3 times more expensive than thermal ablation techniques. So it's very difficult to switch or to change the practice, whatever. So I guess we will be challenged by all these circumstances, but as a societies and this kind of platforms like we are here now, we have to always be in line with the scientific evidence and try to push the policies as well at the level of the insurance companies.
Thank you so much, Martin. Just one quick final remark. I see we have Carlos Bonet. I don't know if he's listening to us. Carlos, are you with us? If not, we conclude with this and we move. Are you here, Carlos?
Sí.
Carlos, it's so nice to have you with us. It's a surprise because you are a huge expert. So I saw you in the audience. Would you like to make a final comment, considering your huge expertise in thermal-tumescent?
Sí.
Maybe it's like a difficult connection. Carlos, can you hear us?
Hola.
Maybe yes.
Hola.
Carlos, can you hear us? So maybe he cannot hear us. So no, he cannot hear us. So Khaled, switch off the mic. Maybe he's in another channel, but I would have liked to have his perspective because he's a huge expert in thermal-tumescent. But we will have another webinar on October 2nd on these topics because we will stop next week. Oscar, would you like to tell us why we are stopping next week?
Perfecto. Quiero invitar a todos.
I would like to invite everyone to the Congress we'll be having in Buenos Aires on 25th to 27th of September, where we will have 3 simultaneous rooms and we will have all international leaders. So we want you to participate. We are available for any questions, any comments, and we will be waiting for to meet all of you in the Congress to be held in Buenos Aires. Thank you, everyone. So we'll meet there.
And it is us thanking Oscar because indeed from Argentina, everything started in building these bridges worldwide. So thank you for the vision, Oscar, and all you do. Indeed, in life, it's not just where you go, it's also who you are traveling with. In this sense, I'd like to deeply thank all the societies involved in this MIT project. And in particular, I'd like to deeply thank the board guests we had today, Professor Matthew Jasnen and Martin Maresch. Would you like to have a final word, Matt, from France?
Yes, I would also like to thank all the speakers of these sessions. All has been very fascinating, the discussion and the presentation. I also wanted to thank on behalf of all you, Sergio, Oscar, and Willie. This session are an extraordinary space for discussion with experts in many fields, very big experts. This is an opening to the world that we all need in a format that allows us all to continue our professional and family activities. But I also like in-person Congress too. I'm also delighted as president of French Society of Phlebology to be able to be with you and to share. I wish you all a very, very good weekend. Thank you.
Thank you so much, Matt, and to all your board for all you're doing for international activities also with the French Society. I really encourage everyone to have a look at the website they have. There are like many educational activities coming from what I define the cradle of phlebology, because everything started there. And I say also a little bit in Italy, indeed we are cousins, let's say so, historically speaking. We go now to Martin for a quick remark from Middle East. Martin?
No, thank you very much for another fruitful webinar. Not only clinical practice, but also, policies are important, and I guess we'll move forward. Looking forward for the next weekend, for the last of these 3 Venus webinars, and looking forward to meet in person, Sergio.
Thank you so much, Martin, and thank you so much to all the stellar faculty who made today possible. Thank you so much to Alpha Sigma and Medi for making everything possible in an unbiased way, also in a field that is not of their direct interest, but it is their interest, evidently, the education. It is our interest to gather together in person as soon as possible, as Professor Jasnan said. So we look forward for being together in Dubai, also for some nice social gatherings like we had in the past. This picture was from the Winter 2019 meeting. We look forward not just, of course, for gathering together in person for the pleasure of being together, but also for the responsibility of reaching out for our patients and our colleagues fighting fake news, as we said before. So I deeply thank all the more than 70 societies involved. I remind you the possibility of reporting eventually encountered fake news in the dedicated website, taking part in the consensus document that will be presented in the beautiful Dubai, of course, next February during the earthquake of the Universal Expo. Until then, we really look forward for a massive presence in Buenos Aires next week, and we will see each other from Middle East on October 2, and we greet you with indeed a nice video from Buenos Aires, where we'll be virtually next week. Thank you so much to everybody. Ciao.
Ciao.
Los esperamos para compartir junto a los referentes más sobresalientes de la artribología y lifología mundial en este evento imperdible en un nuevo formato de reuniones sociales y académicas. Siguiendo entonces las recomendaciones indiscutibles de las autoridades de salud, el Congreso Buenos Aires 2021 se realizará los días 25 al 27 de septiembre, convirtiéndose en el primer encuentro internacional híbrido en la región. Queremos darles entonces la bienvenida.
Thank you all. See you in Buenos Aires. Have a nice weekend. Ciao.